Hello, I'm Professor Shane Dark of the National Drug and Alcohol Research Centre at the University of New South Wales. Welcome to today's lecture on hallucinogens and the body, which forms part of our series of lectures on drugs and the body. To begin with, what do we mean by the hallucinogens? There are a range of substances. They're sometimes called psychedelics. They're characterised by altered levels of consciousness and, as the name would suggest, hallucinations, visual or auditory, or they're really pseudo-hallucinations, because in a true hallucinosis the person is unaware that it is a hallucination, whereas the effects of hallucinogens or psychedelics is that people know what they're seeing isn't real. They're looking at colours on the wall or whatever, seeing synesthetic things like seeing, sound, that type of thing. But people are aware of this. The colloquial term used for a lot of this is these sorts of experiences is tripping. Let's look at the major types of hallucinogens before we examine their effects. There are a number. Probably the most widely known is LSD. It's a synthetic hallucinogen, typically sold in a liquid soaked in blotter paper. What you see with this is very uneven concentrations, that the edge may have a different concentration than the middle. It's unclear how much has been used. These are very, very powerful drugs, all of the hallucinogens, but LSD, the concentrations are extremely low that cause major psychotropic effects. So I'm always puzzled when people talk about microdosing of LSD, because essentially all LSD is microdosing. It's such a powerful substance. The second one I want to discuss is psilocybin. This is the active ingredient in magic mushrooms. These can be taken in a number of ways. People can simply eat the mushrooms. People can eat them in omelettes. Again, with all the hallucinogens, dosage matters because they're highly potent, and controlling dosage is very difficult. How much psilocybin's in that mushroom, for example. Mescaline, this is coming from the peyote cactus, the buttons crowning the cactus, more common in North America than from where I'm broadcasting from in Australia. Finally, I want to talk about two other hallucinogens that people may not typically think of in this class, but they certainly are in this class. They're both dissociative anaesthetics. Firstly, ketamine. It's a dissociative anaesthetic. It's used for, indeed, anaesthesia because it has a safer profile in terms of respiratory depression. It's also, in recent years, being used in the treatment of mood disorders, mainly with depression. This is generally an in-house, inpatient administration of the drug. And there is some preliminary evidence for its efficacy in treatment refractory depression. However, it's widely used as a recreational drug and comes in a number of forms: powder, pills, but quite often in liquid form, dissolved in liquid. The final one I wish to discuss is phencyclidine, PCP, angel dust. This is far more common in North America. It was originally in clinical practice as a dissociative anaesthetic. Its use was phased out in the mid-60s because of the serious side effects associated with the drug, which I will discuss shortly. It can come in powder or liquid form. So there are a range of different hallucinogens, and because they are quite disparate, their effects upon the body are going to be considerably different depending on which one we're talking about. We've outlined the range of hallucinogens that we'll be discussing in this lecture. Let's examine the acute effects, the toxic effects of these drugs A great deal of the risk associated with these drugs is the acute risk while intoxicated, because use patterns tend to be sporadic. That is less the case for ketamine, but for drugs such as LSD, it is typically sporadic use, so it's acute risk rather than chronic, although there can be chronic effects. If we look at LSD, psilocybin and mescaline, which fit together quite neatly, blurred vision, confusion, delusions, an acute psychotic state. Essentially what a LSD trip, for example, does is induce an acute psychotic state. They can produce hypothermia, that is high temperature, which can be clinically significant if not managed, nausea, tachycardia, accelerated heartbeat. We see this with a lot of stimulant type drugs, and the border between stimulants and hallucinogens is grey and nebulous, and tremors. Let's move on to ketamine toxicity. This is very different. Ketamine can cause high blood pressure, hypertension. This is very unusual in terms of anaesthesia. This is something that's not seen with other anaesthetics except for PCP, but it's a major clinical concern relating to ketamine administration in a non-medical setting. Hypothermia, which is elevated body temperature, this can be clinically significant. Muscle rigidity, people talk about falling into the K-hole, being unable to move, unable to respond. Tachycardia, that is an accelerated heartbeat, and prolonged sedation. So they can be, because the dose taken in a non-medical setting can vary wildly, and depending on other drugs are used with this substance, particularly when we're looking at drugs like alcohol, which it's commonly used for, they can prolong sedation, which can have serious effects such as I've said, muscle rigidity and the problems that may be associated with any prolonged proneness in the one position. Finally, in terms of toxicity, PCP, convulsions, again, hypertension and hypothermia. It has this in common with ketamine. Muscle rigidity, again, respiratory failure, tachycardia and vasospasm. PCP is a particularly dangerous drug. Of all the types of stimulants we're discussing, I think it has the most serious acute risk profile. Let's examine the effects of hallucinogens on the heart. Again, this depends on what drug we're talking about. Taking LSD, psilocybin and mescaline together, which typically do seem to clump together in terms of their effects, there are effects upon the heart as a result of hypertension. They are known to cause accelerated heartbeat. Also, bradycardia, which is slowed heartbeat depending on the individual's reaction to the drug. Ketamine, the effects upon the heart will come through, again, hypertension and tachycardia. So we're seeing this with all of these. It's those two factors are also true of PCP. You get the hypertension and the accelerated heartbeat. PCP is a direct cardiac irritant, however. It may cause arrhythmias, that is, an irregular heartbeat, and vasospasm, that is, spasming of the vessels in the heart. There are also effects upon the brain that we need to consider. Again, taking LSD, psilocybin and mescaline together, we see an increased risk for serotonin syndrome. This is something that is commonly associated with MDMA, ecstasy, but is also seen for these drugs. This is an excess of serotonin in the system, and it can result in confusion, hypothermia, muscle rigidity, and indeed respiratory collapse and coma. With all of these, I'm not suggesting everyone who takes any of these drugs is going to have these effects, but the clinician, indeed the general user of these drugs, needs to be aware that these are consequences known to be associated with use of these drugs in some occasions. Ketamine leads to increased intracranial pressure due to the hypertension we've discussed before, which makes it an unusual anaesthetic. And this is why it's very unwise, in my opinion, to be using this outside a medical setting, particularly in unknown dosages. This can lead to an increased risk of stroke. We also see this with angel dust, with PCP, an increased risk of stroke due to the hypertension that it can induce. With all of these, everyone who uses these drugs is not going to have these effects. Some people will, and I should point out that if you take a drug like ketamine, I have done research in this country, Australia myself, documenting ketamine-related deaths in non-medical settings. Moving to the liver, there are a number of effects we need to consider. However, LSD, psilocybin and mescaline are not toxic to the liver. Ketamine, however, is. It's directly toxic to the liver, and that liver damage is associated with more frequent use. So more frequent use over a longer time will increase the risk of liver damage. And this is, perhaps not surprisingly, exacerbated by the use of alcohol, which in another lecture in this series on alcohol, we discuss the effects of alcohol on the liver. It is hepatotoxic. This is also true of ketamine, and using those two drugs together, which they commonly are, is going to increase the risk of liver damage substantially. And finally, PCP, angel dust, there have been cases of malignant hypothermia, that is bodily temperature so high, say 40 degrees Celsius plus, which cannot be brought down, which can cause necrosis, that is death of cells in the liver. Let us move on to the kidneys. There are a range of effects we need to consider. LSD, psilocybin and mescaline are not known to be toxic to the kidneys or associated with kidney disease. It's a very different story with ketamine. Regular use is associated with what is known as ketamine bladder, urinary bladder and kidney disease. Up to 30% of regular users develop ulcerative cystitis, a thickening of the bladder wall and contracted bladder. These, of course, all link in with kidney disease. Finally, PCP, we see rhabdomyolysis and renal failure. This is due to muscle rigidity and hypothermia, leading to breakdown of muscle tissue, releasing toxins into the blood, which are damaging to the kidneys. We have been discussing the effects of hallucinogens upon various systems of the body, but we also need to look at mental health, particularly if you will recall the experience of drugs such as LSD is an acute pseudopsychotic state. It looks very much like acute psychosis. There's two things we need to consider here. Firstly, hallucinogen persisting perception disorder, HPPD, commonly known as flashbacks. There's two types, HPPD1, which is short-lived, benign and reversible. That is flashbacks, as people say. I suddenly felt like I was tripping again. This is real. They're not making it up. It is a real phenomenon. And HPPD2, which has a slowly reversible or indeed irreversible course with greater impairment and a poorer prognosis. It's very hard to predict whether people are going to develop these, and of course not everyone is going to develop these, but I'm wanting to point out that these are documented effects on mental health associated with hallucinogens. The next thing to discuss is psychosis. It's not surprising, given what we've talked about to date of the psychotic-like acute effects of these drugs, that there is an association with psychosis. Paranoid delusions, beliefs, perceptual abnormalities, anxiety, panic symptoms. They can be acute effects that is acute psychotic drug-induced psychosis. However, those effects typically go away when the effects of the drug go. There have been, however, examples of psychotic symptoms lasting more than 24 hours following the administration of hallucinogens, and people with a family history of psychosis or schizophrenia, for example, would be well advised to bear this in mind if thinking of taking drugs that can induce psychotic states. Finally, there's a range of other conditions that we need to consider. All hallucinogens have an elevated risk of injury. This is not surprising. Person has perceptual disturbances, the world looks different, and they're quite often dissociated. Their sense of reality is impaired. Ketamine has been associated also with the development of what's called K-cramps, intense abdominal pain. Now, ketamine in particular, I've talked about the risk of all drugs, all the hallucinant drugs, having an increased risk of injury. That's true of ketamine, but its anesthetic properties mean that the person may not even be aware they're injured, so they can hurt themselves without being aware of that. So they're at risk of injury, and they're at risk of injury and not being aware that they have an injury. And this is also true of PCP. There's an increased risk of injury, and again, as a dissociative anaesthetic, there's an increased risk of the person being unaware that they've injured themselves and be more likely to injure themselves without such awareness. The other thing that we need to note, that PCP is notorious for its association with violent behaviour, acute, sudden, violent psychotic behaviour that was certainly when in the 70s onwards, in the 80s onwards, this was highly discussed in the general media, requiring a number of people to hold someone back. This is real. The risk of violence with PCP does make it stand out from the other hallucinogens, and it is something that needs to be borne in mind if someone is using such a drug. We've covered a wide range of issues in the lecture on the hallucinogens and the body. These are all covered in the Pocket Guide to Drugs and Health, which provides page at a glance, dot point summaries of the effects of each of the major drug classes upon the body and indeed upon mental health.